Hello people, in this video we want to look at hydatidiform mole. So basically what is this hydatidiform mole? It's a benign condition, it's a placental tumor, and all this happens because of wrong fertilization. Okay, so now we are looking at obstetrics, guys, focus here. So we are not looking at pathology. Now we will look at the same topic in terms of obstetrics. In pathology you have seen about it, basic stuff. Basically what happens when there is a teenage pregnancy or an old age pregnancy, the fertilization does not happen correctly. So there can be an incorrect fertilization which will lead to what is called as a molar pregnancy. Okay, it is also called as hydatidiform mole or vesicular mole. All the words are same. Okay, just look at this complicated diagram which has been drawn here. Basically, are you seeing here that all these are trophoblastic conditions? That is something to do with the placenta. Okay, whatever you're seeing here are the benign conditions, and whatever you're seeing here, this is normal pregnancy, normal abortion that happens, all that is also a benign condition of your placenta. But it can happen sometimes that there is, like I told you, a teenage pregnancy or an old age pregnancy that can lead to a wrong fertilization. When that happens, the pregnancy is called as a molar pregnancy. It is also called as a hydatidiform mole or a vesicular mole. All these terminologies will refer to one thing. Okay, usually molar pregnancy they will refer to the complete one, but anyways remember hydatidiform mole, vesicular mole, molar pregnancy, all this happens if there is something wrong with the fertilization. We will come to all that. Okay, so there is something on this side. What is there on your, which side is this? Right side for you? Yeah. So all these are cancerous or neoplasms. Okay, where you have something invasive mole. This is only locally invasive actually. Choriocarcinoma, you should know. Carcinoma, obviously that is a wake up word. Choriocarcinoma, which will be a malignancy, and this is carcinoma will affect what? The epithelial cells, isn't it? And then you have placental site trophoblastic tumor, PTT shall we call it as, or PSTT, what do you want to call it as? So these are some conditions that you should know. So many terminologies, right? Basically here we have the benign ones, here we have the invasive ones, you can say. This is normal pregnancy, normal abortion, that also can lead to some of these neoplasms. Vesicular mole is when there is incorrect fertilization and there is a molar pregnancy. Those also can lead to these neoplasms. Is it becoming too much, guys? Just remember, there is some persistent trophoblastic tissue, okay, because of which all this will happen. So after a normal pregnancy, there can be persisting trophoblastic tissue, that is the placental tissue, right, which can lead to malignancy. Okay, so you should know that in that case, when normal pregnancy leads to choriocarcinoma, that is one of the worst prognosis. Usually it doesn't lead, okay, but if it leads, it's going to be a worse prognosis. So let's get started, guys. So did you understand that placental tumors, due to wrong fertilization, you can have placental tumors? This is how the placenta cross-section looks like, right? Under the microscope, you're seeing the villi. The villi you can see here. Outside you have syncytiotrophoblastic, inside you have the cytotrophoblast, right? And then each villi is separated by some space, and there is a lot of maternal RBC there, okay? So basically, the risk of this molar pregnancy happens if there is a teenage pregnancy, or for 40 to 50 years, or late pregnancy, basically, you should understand, okay? So in this hydatidiform mole, or vesicular mole or molar pregnancy, you can have two types, where you have the complete or the partial. Okay, complete is where all the three layers of the trophoblast are affected, right? And partial mole is where only the syncytiotrophoblast is affected. Okay, let us look at this. Why is it called hydatidiform mole? Means the villi will like a drop of water. Okay, so it'll be like a shapeless mass. So normally what happens, guys? So there will be an ovum, right? And then there will be a sperm which comes and fertilizes it. Okay, now what will happen? There will be an embryo, zygote, right? Which color shall we use for that? Okay, there will be an embryo, right? Zygote will form and zygote will become embryo. Then it will become fetus. Okay, fine. Okay, now we have to understand two things here. One is called the complete mole, and then the other one is called as partial mole. Okay, so let me write it here. There's something called as complete mole and partial mole. All these are wrong fertilizations. Okay, let me explain of the partial mole. This is easy to understand. So there is one ovum and there are two sperms coming. Okay, so now what will happen? There will be triploidy. Okay, triploidy. So there will be 69 chromosomes. So this one will not survive, obviously. So this initially there may be a heartbeat or something, and finally the fetus will die. So here they are showing you this will be like this is called as a partial or an incomplete mole. Triploid, there is 69 XXY or 69 XYY. Okay, 1 maternal and 2 paternal chromosomes, right? Haploid chromosomes. So what will happen? 2 chromosomes, 2 sperms are fertilizing 1 egg. Okay. So this is a partial mole. What happens here? The fetus will die in the first trimester. Okay. And there can be a missed abortion. What happens here is there is not going to be much rise of HCG, human chorionic gonadotropin. So look at what they are saying. In partial mole, there will be a fetus. It's more like a missed abortion, right? The villi will be that hydropic degeneration of the villi, what we are talking about, that will be a focal degeneration. It's not diffuse degeneration like in complete, right? That's why the word partial. Okay. And then what will happen here? Again, focal trophoblastic hyperplasia. The uterus size will be less than the date. Okay. Then you should know here, the karyotype will be triploid. The beta HCG will not be so high. A slight elevation only you will see. So this much you should know about partial mole. Let's revise this from your pathology textbook. Partial mole, triploid, yes, or it could be tetraploid also. Missed abortion is the presenting, the way they present. Then what will you see here? The embryo may be present. How will the villi be? The villi will be present. The villus change will be focal. Syncytial trophoblast only they are saying is affected. Then mainly you focus here that it usually doesn't change into malignancy or choriocarcinoma. Okay. So look at this. This is partial mole, how they are describing. There is the ovum here, 2 sperms, 69, XX, X or XY it can be, is it? So basically, the fetus can be present. So guys, we have looked at partial mole. You understood. Now let us look at complete mole. Usually whenever they refer to vesicular mole or hydatid mole or molar pregnancy, they're usually referring to the complete one or the classic one. Okay, this is the complete or the classic. Now focus, we are looking into the complete or the classic. So what happens in this complete mole, right guys? Look at this. So there is an ovum here. It's empty. It has no chromosomes, no genetic material. One sperm is coming and trying to fertilize it. So it will become 23X, right? The same thing will undergo endoduplication and it is forming 46XX. This is kind of androgenesis. The entire genetic material is coming only from the father. Okay, remember this is only paternal. In complete mole, it is only paternal part that is coming. The ovum is empty. Here 2 sperms are coming, 46XX or 46XY it can become. And again, this will continue to divide, right? What happens here? This embryo will die early in the development itself. It will die. Embryo will die early in the development. And how will that be? The villi will continue to proliferate. So you can see here extensive trophoblastic proliferation. It involves the entire circumference of the villi, right? In addition to extravillous islands of trophoblast proliferation. So basically there will be grape-like clusters in the uterus. The uterus size will be very large, but there is no fetus. Mainly thing you have to focus here, no fetus. And here the presenting complaint will be a bleeding PV. Okay. Grape-like cluster snowstorm appearance in the ultrasound. See this snowstorm appearance. Okay. So this is showing you hydatidiform mole. So usually whenever we say hydatidiform mole, molar pregnancy, we usually refer to the complete, the classic type. Can you see all this? Okay. Look at this image here. Again, hydatidiform mole showing clusters of vesicles of varying size, and this one is histological section of the hydatidiform mole showing hydropic degeneration of the villus stroma with absence of blood vessels and trophoblastic proliferation. Absence of blood vessels. So remember guys, when you will write the differences here in here in complete mole, the blood vessels are not there. So blood vessels, they are saying it is present in the partial one, guys. So remember that. Okay, so we have marked that here. So in partial one, blood vessels will be there, right? Partial mole blood vessels are there, and even the malignancy, there will be blood vessels and they will be abnormal. Necrosis will also be there in malignancy. Okay, just remember that here. See here, one more thing you have to see here. This is complete and this is partial. and this is the malignant one, choriocarcinoma. The complete one has more chances of becoming malignant. The complete one, complete vesicular mole, hydatidiform mole, or the molar pregnancy, if it is complete, then there is more chance of becoming a malignancy. Where are blood vessels, guys? Blood vessels are present in the partial one and also in the malignant one. Complete does not have blood vessels. Look at this hydatidiform mole in the process of expulsion, showing clusters of vesicles. Okay. As a doctor, how do you think these people will present to you? So look at this. Okay, they will have 8 to 12 weeks of amenorrhea. Okay, they'll come with so they will come with features suggestive of a normal pregnancy. Okay, but they can have vaginal bleeding, lower abdominal pain. They'll have a lot of vomiting because HCG is more, isn't it? Beta HCG is more. They can also come to you with thyrotoxic features because of all this increased beta HCG. They can have embolization because of the trophoblastic cells, and they can come with breathlessness due to pulmonary embolization, right? That's again scary. So there can be expulsion of grape-like vesicles. It can be there possibly, okay? Then what will you look as a doctor? You will see that the patient looks more ill than accounted for. You can see pallor because of blood loss, probably. There can be features of preeclampsia, hypertension, etc. And classical clinical features of complete mole. Please look at this, very important this is. So we will have what? Abnormal vaginal bleeding, lower abdominal pain, hyperemesis gravidarum. Okay, they can have preeclampsia, they can have a big uterus, they can have absent fetal parts. Mainly look at this, they have absent fetal parts. And what is this? FSH, fetal heart sounds, absent fetal heart sounds also. And then there will be expulsion of this vesicular tissue, which we showed you. There can be theca lutein cyst of ovaries. So the ovaries have some issue. Theca lutein cyst of the ovaries. There can be hyperthyroidism, which is rare. There will be increased HCG level, more than 1 lakh. They are saying international units per ml. Milli international units per ml, is that what they're saying? And in the ultrasound, you will see snowstorm appearance, which you already saw. So here they're talking about the abdomen, the size of the uterus, fetal parts, etc. Then vaginal examination. They're talking about intral ballotment. How will be the ovary? Enlargement of the ovary, bilateral or unilateral, theca lutein cyst. Okay. So this is important. Then, now that you know all this, what the differentials also you have to keep in mind. What could be the differentials of what are we talking about? Hydatidiform mole, right? Or a complete mole. It could be a threatened abortion, right? It could be an actual normal pregnancy which is going in a threatened abortion. It could be an ovarian tumor. Fibroid it could be. Multiple pregnancy it could be. This is very important. Look at this. Here they're showing a very interesting case where there is one sac, twin pregnancy. This is one sac has a molar changes of placenta. You can see here they have marked it as a mole, and the other one can have a fetus. So this is kind of very interesting, right? So there is coexistence of the moles and a fetus. They're saying that the pregnancy ended in miscarriage at 18 weeks of gestation due to complication of excessive hemorrhage. Okay. Now that you looked at the differentials, now let us look at the complications of molar pregnancy. We already told you that they will go into bleeding, so they can go into shock, they can go into sepsis because of there are no protective membranes. Vaginal organisms can creep into the uterine cavity, so they can go into some infection and they can go into sepsis. Okay. Then there'll be degenerated vesicles, etc., favoring the growth of bacteria. Perforation of the uterus can happen. Why? Because of the perforating mole. Okay. Because of perforating mole, it can happen that the uterus can get perforated. They can again go into preeclampsia. They can be having pulmonary insufficiency, pulmonary embolization of the trophoblastic cells. Okay. Coagulation failure. And as such, they can go into development of choriocarcinoma. They can go into late, it can become a malignancy. What are the risk factors for malignant change if the patient's age is more or less, etc.? If the serum HCG is greater than this 1 lakh milli international units per ml, is it? Uterine size is more than 20 week size, or if there is a previous history of molar pregnancy, or if there is a theca lutein cyst, right, ovary, which is greater than 6 centimeter diameter. All these are risk factors for malignant change. Now, how will you manage this case? Now, let us look at the management, guys. Management, you will do suction evacuation of the uterus. Remember, SE, suction evacuation you will do. Supportive therapy you will do, that is if they have anemia, treat that. If they have infection, treat that, right? They're talking about infusion of Ringer's solution, etc. and supportive care. Basically, you have to regularly follow up with these people. You have to counsel them. Basically, they're also grouping these patients into two groups, Group A, Group B, where the B is where the uterus remains inert. Basically, the cervix, they will have to dilate and then they'll have to do the SC. Okay, see, they're talking about the cervix is tubular or closed. They'll have to dilate the cervix and then follow it up with suction and evacuation. And when you're doing the suction evacuation, remember the patient can go into a pulmonary insufficiency because of a pulmonary embolism. They can go into a thyroid storm. Okay, they'll have in presence of a hyperthyroid state, right? You will have to make sure they can go into thyroid storm. Focus, guys. So they'll have hypothermia, delirium, convulsions, coma, cardiovascular collapse, etc. So you will have to administer beta adrenergic blocking agents. Remember, in these people, guys, routine follow-up is very important. You have to tell them not to get pregnant, because if they get pregnant, it is very difficult to know whether the HCG levels are because of the new pregnancy or because of the persistence of this trophoblastic disease. Okay, where are we? So, till the serum HCG level becomes negative, this is very important. So, here they are telling contraceptive advice. The patient is advised not to get pregnant at least for a year, okay? Because it can cause confusion, whether it is because of the fresh pregnancy or a persistent GTD. Now, remember here, if all this doesn't work, then they have a lot of other treatments like methotrexate, actinomycin, etc. They have a MAC regimen where it is methotrexate, actinomycin, cyclophosphamide. For actually, they're talking about chemotherapy here. Then they are adding some E and O also for this MAC. That becomes, what is that? Etoposide, and O is vincristine. Vincristine also they are calling it as oncovin or something. So O. So it will be EMA-CO, something like this, okay? Let's just go back to this and understand again, guys. Trophoblastic conditions, normal pregnancy, there can be abortion, etc. Those also will have placenta. Then there can be this wrong fertilization, which leads to vesicular mole, in which you have complete and partial. Usually the complete one can go into choriocarcinoma, right? The treatment for which is chemotherapy, which we told you. Invasive mole is a condition where it is locally invasive only. It is also called as some chorioadenoma destruens, okay? The same thing, invasive mole, same thing. It is called as chorioadenoma destruens. Then you have choriocarcinoma, right? And then you have placental site trophoblastic tumor. Here, basically, the intermediate trophoblast is affected, okay? And this does not make HCG. This makes human placental lactogen, remember? And again, in this surgery is what they want to do here, okay? Invasive moles also, they'll do surgery. Choriocarcinoma, they're talking mostly about chemotherapy, okay? Finally, again, they can talk about hysterectomy, that is surgery, okay? So, did you understand choriocarcinoma? Look at this one, guys. Normal pregnancy never becomes an invasive mole, okay? But normal pregnancy can become a choriocarcinoma. In case normal pregnancy becomes a choriocarcinoma, it will have one of the worst prognosis. Remember that, okay? If there is a persisting trophoblastic tissue after normal pregnancy leading to choriocarcinoma, it will have the worst prognosis. So look at this table now. Classification of gestational trophoblastic disease from your textbook. Basically, hydatidiform mole, complete or partial it can be. This is benign condition. Okay. Now coming to the other side where they're talking about neoplasm kind of thing. You have invasive mole, which is locally invasive. Then you have the choriocarcinoma, and then you have the placental site trophoblastic tumor, which makes human placental lactogen, right? It doesn't make HCG. Now coming to choriocarcinoma, you have two types, non-metastatic and metastatic. Anyways, we will concentrate on the metastatic one. There you have something called as low risk and high risk. Let's look at the high risk one, that is poor prognosis it will have. What and all will be the features of poor high risk choriocarcinoma? So basically there can be very high HCG, long duration of disease. It has already metastasized to the brain, to the liver. There is failure of chemotherapy. It is following a term pregnancy. We told you, right? After normal pregnancy, if there is choriocarcinoma, it has poor prognosis. And if there is a WHO score of greater than 7, you can understand some staging, etc. If the score is greater than 7, there will be poor prognosis. Okay. So it can metastasize brain, liver, etc. Remember, HCG, if it is more, initial serum HCG is more, then it's bad. If it is following a normal pregnancy, it's bad. If it's not responding to chemotherapy, it's bad. Okay, all that you understood. Okay. Hope you have understood gestational trophoblastic diseases, guys. We looked at all the conditions, benign and malignant, you have looked at. Look at the scheme of management of hydatidiform mole. Let's focus if it happens that she's in the process of expulsion, right? That means what will you do? You'll give in IV crystalloids, you'll give blood also if it's required, then you'll accelerate evacuation. It's already in the process of expulsion. You're doing accelerate evacuation, suction evacuation, plus they are going to do some gentle curettage because you don't want it to go into carcinoma, right? Then come down here, you will follow up at least for 1 year. You will monitor the serum or the urine HCG, very important. If it remains, if it returns to normal, good. Otherwise, you will have to exclude new pregnancy, check if she's pregnant again, etc. Or you will have to check if it is a persistent trophoblastic disease, okay, and if it is metastasizing, etc. The other condition here is if the uterus is inert, then you will not go into evacuation immediately. You will correct the anemia and then etc. You will, if she's desirous of having child, again here they are talking about evacuation, same thing only, right? If she has completed family, there's a perforating hydatidiform mole, they are doing a hysterectomy, right? If she has completed her family hysterectomy, otherwise they're doing evacuation. They are doing vaginal evacuation or abdominal hysterectomy if the cervix is unfavorable, looks like. Anyways, guys, look at this. Again, they are following it up with curettage in select cases. Okay. So in this video, we not only looked at the benign conditions, we looked at the malignant conditions, we looked at the treatment of these conditions also, right? Exactly how to treat, what is the protocol scheme of treatment of hydatidiform mole, okay? Just a word I want to put for you is this is hydatidiform mole, okay? Don't get confused with hydatid cyst, which is caused because of parasite. That's it for now. Bye-bye.